This is the third webinar in our series on human factors and primary care. Today, we will hear from Rosie Benneyworth, Chief Executive of the Health Services Safety Investigation Body in England. Human factor science is a fundamental pillar of the WHO Global Patient Safety Action Plan 2021-2030, and the Human Factors Core Group was established two years ago. Human factors is a scientific discipline. It's concerned with the understanding of interactions about humans, ourselves, and other elements of health systems. The science is about designing systems in such a way that human well-being, our own well-being, that of the staff and our family members, overall system performance are all both safe and optimal. For family medicine, our vision is that by applying human factor science principles in the strategic and day-to-day activities at individual and organizational levels, our primary care patients will have the highest attainable health and well-being with care that is both patient-centered and free from avoidable harm. As WONCA is a global organization, our Human Factors Core Group's mission is to lead within the organization on human factors integration in family medicine worldwide, by supporting family medicine teams to develop their own human factors language, applications, research and education, adapted for their own local circumstances. So a few practicalities for today. If you need to contact us afterwards, you can reach us via email and we will put that in the chat. The chat is active for all of you to let us know which regions or cities are you working in, what is your background, and what made you join our webinar. For this, use the group chat. The chat is also for you to put up your questions for our speaker, Rosie Benneyworth, in the chat or raise general discussion points or ideas. Another core group member, my colleague, Dr. Roanne Osborne, will assemble your questions from the chat for later in the question and answer session at the end. Roanne will for now introduce you our speaker. Over to you, Roanne.
Thank you so much, Maud, and welcome to everyone. I have the pleasure of introducing our speaker today. Rosie joined the Healthcare Safety Investigation Branch in August of 2022 and is now the Interim Chief Executive Officer of the Health Services Safety Investigations Body, HSSIB, having led the transition to the new arm. She has a long-standing interest in improving the quality and safety of care that people receive and has had several senior leadership roles in health. This has included Chief Inspector of Primary Medical Services and Integrated Care at the Care Quality Commission, CQC, Managing Director of the Southwest Academic Health Science Network, and as a Clinical Commissioner with Somerset Primary Care Trust and Clinical Commissioning Group. Rosie has a background in primary care and worked as a GP in Somerset for 15 years. Rosie has significant non-executive experience and is currently a non-executive director on the board of University Hospitals Bristol and Western NHS Foundation Trust. She has also held roles as a non-executive director and vice chair of the National Institute for Health and Care Excellence, NICE, and a trustee of the Nuffield Trust. I turn it over to Dr. Benneyworth for her presentation. Thank you so much.
Thank you so much, and I'm absolutely delighted to be here, and thank you for that introduction. I'm just going to try and share my screen, so hopefully you'll be able to see my slides. Can everyone see my slides? Great, fantastic. So thank you. So as we just mentioned, I am Interim Chief Executive of the Health Services Safety Investigations Body, and I'll explain what that is shortly. But just to set the scene, I am a GP by background, as explained. I'm not a human factors expert, just to make sure everyone's aware. I have a long-standing interest in quality and safety, but I'm very lucky because I work with a team who are all human factors experts and all kind of experts in safety science, and I have learned from them. But I think in terms of the absolute technical human factors expertise, I can point you to my team, but I'm not, I don't want anyone thinking I'm the kind of human factors expert in the room. Having said that, I think human factors is absolutely vital in terms of us changing patient safety, us looking for a new approach. And I'm just going to start by setting the scene as to why this is important. And I think just let me move my slides along. So I think we need to stop seeing patient safety as something that happens after an incident that happens and start thinking about how do we have a much more proactive approach to patient safety to avoid harm before it starts. And we recently wrote a report about safety management, and one of the things that struck me from that report was a comment that someone had made that said, actually in healthcare, we shouldn't talk about do no harm. We should talk about first do some harm, because what we do often is say, let's wait until we've got the data to prove it's a problem. Let's wait until, you know, we're sure this isn't a one-off, and then we'll do something about it, rather than thinking about actually how do we identify those areas that people are concerned about, that there's risk in, and how do we take a much more proactive approach. And just some stats to kind of set out again why this is important. And apologies, you probably know this already, but it's estimated that in low and middle income countries, there's 134 million incidents a year, which equate to 2.4 million deaths from safety failure. In high-income countries, it's estimated that 1 in 10 hospital admissions result in safety failure. And in primary care and out of hospital care, that figure is higher, estimated to be higher, somewhere in the region of 1 in 4. In the UK, where I am now, it's estimated that if we match the top 10% of OECD countries from avoidable deaths from treatable causes such as sepsis and blood clots, then we would have up to just under 14,000 less deaths a year. And I think when we're thinking about the statistics, we need to think that every one of those numbers represents a life lost, a family changed, and eroded trust in healthcare. And I think we're seeing, you know, the potential impact on trust in healthcare that we need to think about. And I think we also need to think about the staff well-being. I'm sure many of you have had incidents in your clinical time. I certainly have had, you know, a number of incidents in my time as a clinician where something went wrong. You feel devastated as a clinician when these things happen. Sometimes it can be career changing. Sometimes it can even be career ending. And at a time when the WHO is talking about a global workforce shortage of 11 million people in healthcare, then I think we need to be thinking about how do we really kind of support staff? How do we think about health and well-being of those people who are working in healthcare? And how do we really make sure that they are working in systems, processes and environments that support them to deliver safe care? So I think we need a different approach to patient safety, and our organisation is one step towards that. Just to kind of reinforce the point, given the financial climate that we're all working in, and I'm sure all organisations that you're working in are kind of struggling with how you manage the financial situation and the pressures on the finances, as well as the safety implications. You know, the OECD suggests that 13% of healthcare spending across OECD countries is due to avoidable safety failure. And then when you take that a step further, they've recently published some work around diagnostic error. And of course, this is very pertinent to primary care, but they looked at overdiagnosis, misdiagnosis and underdiagnosis, and they felt that 17.5% of total healthcare spending was spent on diagnostic error. And so if you think about even a fraction of that being reinvested into good quality care, the good news is that actually they said that only a small amount of money, a small investment would actually have a huge impact in terms of return on investment. And I can send these slides out afterwards with all of this information. But hopefully that's done enough to set the scene about why we need to continue to make sure patient safety is right at the core of the discussions, especially at a time when there's so many other demands and pressures on the healthcare services. And there's another slide just to emphasize my point about medication errors in the UK, and certainly with primary care, you know, in the NHS in the UK, 237 million errors in medication a year. So I don't know what that is globally, but I mean, huge potential for improvement. What do we do? So we are an organisation that essentially investigate problems that are of national concern. So we look at problems that don't just happen in one provider or one organisation or one GP practice, but are problems that are happening right across the country. And we like to focus on those areas that are really complex, that actually sometimes cross multiple parts of the system, sometimes involve lots of different parts of kind of the healthcare system that patients interact with, and look at those areas that actually don't just require a local solution, but require national change in policy, and national change in guidance, and national way of looking at things. And we do about 20 of these investigations a year. Importantly, and I think this is important in all of our work, we are trying to create a culture which doesn't blame individuals, and we are set up in legislation so that we don't apportion blame or liability. And we are not a regulatory body, and that's important. We're about learning, sharing that learning, and making changes at a system-wide level that are going to improve care for patients. And an important thing for that is that actually our legislation that underpins our organisation means that any information that is shared with us through the course of an investigation is protected by law. And that's really important to allow people to speak freely about things that have gone wrong. Too often we hear terrible stories about how people are treated when they've raised concerns, how people have not been listened to, and people sometimes are fearful about talking about things that have gone wrong for fear that they're going to be blamed for something or lose their jobs and things like that. So we work under this special legislation, which is quite unique in the world, where information is protected and it can't be used in legal cases. We can look at anything in the healthcare system in England that creates problems for patient care, but we don't replace local investigations. Our work is very much looking at those systems and processes from a national level. Once we finish our investigations, we make recommendations to national bodies, and our recommendations go to ministers, they go to our government, they go to our Department of Health, they go to NHS England, they go to regulatory bodies, sometimes royal colleges, so a whole range of groups of people, and those organisations have 3 months to respond to us in terms of what they're going to do. The other thing I just wanted to mention before I get into some of the detail about learning for primary care is I just wanted to mention our education programme, and there's a lot of information on our website. We do offer our education programme to people right across the world. And the reason I think this is very important is that I think in primary care specifically, we probably have quite a lot of work to do to think about our response after something goes wrong. So how do we involve patients and families well when something's gone wrong? How do we look at undertaking investigations that really look at the learning and really kind of make sure that that learning is shared across a practice, across an organisation? And quite often we hear that the quality of investigations when something has gone wrong is quite poor or quite variable across England, and I don't know what it's like in the rest of the world. But it's so important that we put in processes that do learn from things that go wrong, and look at that in a way that looks at the systemic factors as to why something has happened, and look at the human factors, look at that through a human factors lens. And so we do have a series of education programs, and we anyone's welcome to have a look at that on our website. And in particular, we're really keen to professionalise investigation. Often we hear that kind of people are bolted on doing investigations on top of their day jobs. And some of these can be very complex. And we're dealing with people who have gone through a huge amount of distress, families, relatives, working with staff as well, and we take a trauma-informed approach to how we engage with people, and so we're very keen to support that improvement right across the system. So how we work is we do a whole range of kind of evidence search to start off with, literature searches. We look at what has been said about a particular topic. And then we go out and we talk to patients. We talk to patients in focus groups. We talk to people who've experienced harm. We talk to lots of national organisations and local organisations. And then importantly, our investigators go out and watch what happens. And what we find is often what people think is happening is not what actually is happening. So we might have a policy or we might have a procedure that says do this. And actually, when you look at what's happening on the ground, people have developed workarounds, they've developed shortcuts, they've developed different ways of doing things that are not what people in senior management positions might think they're doing. And that's often where we find the safety gaps. Often that's where we find things going wrong. And so when you're looking at patient safety, I think it's really important to really understand what is that difference between what we think is happening across the system to what is really happening on the ground, and what staff members are having to deal with, and the complexities and the barriers that are there to stop them doing things. And I just wanted to highlight that and give you an example of the type of thing that we do, and bring out some of the learning from a report which is not related to primary care, but there is a lot of learning. And just to give you an example of that work as imagined versus work as done scenario, when we've just done a lot of work in mental health inpatient units looking at the harm from suicide and how we can support inpatient mental health units to improve. And what we identified was actually the national guidance in England says that you shouldn't use risk assessment tools to identify someone's risk around suicide, because actually someone's risk changes very rapidly and it tends to kind of categorize people in not a holistic way in terms of their risk. So the national guidance says don't use these tools. But when we went out and looked at what was happening in practice, what we found was two things. One was that the IT systems that were being used in these units actually forced people to put low, medium or high risk into their system before you could actually move on to the next screen. And the other thing we found was that actually the coroners were playing quite a significant role in this, because when people were going in front of a coroner, they were saying, where is the risk assessment tool? And they were demanding that from the staff on the ground. So these staff were trying to mix this, trying to follow the national guidance with these local barriers and also these expectations from other parts of the system. And I think that just brings to life the type of thing where actually you could say that individual staff member is to blame. You know, that would be the easiest thing to say. That person's not following the guidance, they're to blame for what's going wrong. But actually, when you look at the situation, you realise it's far more complex than that. And there was really good reasons why those staff members were not able to follow the guidance. And just in that instance, we made recommendations about IT standards, and we also made recommendations, we wrote to the Chief Coroner to try and kind of change that. So just an example of actually how you shouldn't assume that what you write down is always what is happening on the ground. The other reason I wanted to mention this report is that there's quite a lot of learning from this report about how we work with both families and staff members when things go wrong. And what we heard from families is that often the course of investigations and inquests after someone's death and after someone had come to harm was like repeating the same thing time and time again. So I think it's something we need to really explore in primary care, in really kind of how we identify when things have gone wrong quickly, how we are open and transparent with the people that have been impacted, but then also how we quickly work out how we support those families, those patients in a very restorative way to help support them through the process that might happen afterwards. Most patients and families I've met that have been experienced harm through healthcare, what they really want is to make sure that it doesn't happen to anyone else. And that's often the prime reason they want to get involved with the work we do, is to say, please don't let this happen to other people. And interestingly, when we looked at this from a staff point of view, what we heard was often staff feel very isolated after things go wrong as well, and people don't always get the support from their teams. And again, I think this is even more relevant in primary care, where sometimes we're working in a very autonomous situation. People are not necessarily working in a broader team and working on their own in their consulting room. And so I think how we work out how we really support staff and healthcare workers in primary care after incidents have occurred, because, you know, like I said, and I know from my experience, I remember very clearly an incident where I prescribed something for a child that wasn't suitable for under 12-year-olds, and for a whole range of reasons. And it's a really good example of a multiple kind of failure points in the system. And I know that questioned my ability to work as a doctor. I questioned my confidence. You know, it was a real period of reflection for me in terms of, am I competent? Looking back, actually, there was a lot of reasons why that happened and a lot of things we put in place from learning. But I think we all have those moments where something happens in our clinical practice that has a massive impact on us, and we need to support staff to be able to deal with that. I'm going to talk about another area of healthcare, and again, there's a lot of learning here for primary care. And although it might be difficult to see it to start off with, but this is about swabs in hospitals and retained swabs. And this was a really sad story, actually. We looked at where someone went for heart surgery. They were found to have a retained swab when they're in intensive care. They went back to surgery. One swab was removed, went back to intensive care, only to find that they'd actually originally left 2 swabs in place, and so they had to go back to surgery again. And when we looked at this, we looked initially at all of the investigations that had been done around all of the incidents around retained swabs in the country. And the reason I wanted to talk about this particular one is that I wanted to raise something called the hierarchy of intervention effectiveness, because I think this is something we really need to think about, again, in primary care. So when we look at the effectiveness of interventions and the barriers we can put in place to stop safety incidents occurring, what we know is that the interventions that are quite focused on individual people are often less effective than the interventions that are looking at how we change the system. And the reason being, and this example was a prime example, you know, when you look at actually saying to people, we've got to have a policy around this, we've got to train people, what it doesn't take into account is the fact that sometimes you might be operating on people in 3 o'clock in the morning. You might have a queue of people outside your consulting room door. You might have had a terrible day, no sleep the night before. You know, there's a whole range of factors which sometimes influence and impact on how you're able to deliver what you can deliver. So the more we can actually put barriers in place that are actually going to reduce the risk and move it away from actually the individual up into the system and the processes and the environments, the better. And if you look here, the more effective kind of interventions we know can be things like forcing functions. So, you know, locking locking potassium away in cupboards, locking kind of dangerous drugs away in cupboards, automation, computerization, those things, those pop-ups you get on your IT systems that remind you, or the EPRs that remind you that something is due or you shouldn't prescribe things together. And making sure things are as simplified as possible. What's a lot less effective are things like education and training policies and reminders. And when we looked at this actually and looked at what was happening across all of the investigations that had happened about retained swabs, we found that virtually all of the recommendations came out looking at those people aspects. You know, we're very, very good in healthcare, I think, it's saying actually you need to go on training. We need to rewrite the need to rewrite the policy. We need to kind of remind people of the policy, because of course people have forgotten the policy. So there's lots of things like that. And actually what we're trying to do is think about how do we move the system to really think about those system-wide things. You know, what is it in our day-to-day practice as GPs, as primary care physicians, that are going to actually prevent those things from going wrong? What are those strong barriers we need to think about? And then just moving on to the next slide. Sorry, it seems to be glitchy. So I just wanted to spend the last few minutes just talking about some of the investigations that we have done in general practice, and talk through some of the findings that we've done. And just starting with the report on the left, and again, I'll send through all of these slides so you have the links to the report. We looked at continuity of care in general practice, and we looked at the impact on delayed diagnosis. And I must admit, I don't know where everyone else in the world is looking at continuity of care, but certainly it's a feature that we think is really important in England for safety. And we looked at a very sad case actually of a chap whose name was Brian, who was a gentleman with breast cancer, and he'd had breast cancer a few years before, and then came in and saw a series of locums and a series of different doctors about his back pain. But this gentleman had multiple other conditions. I think he had mental health problems, he had diabetes. And so in between these episodes of back pain, he was also having lots of consultations about lots of different things. So the fact that his back pain persisted wasn't actually picked up through the records, and it wasn't picked up by those individual doctors. And what we found, sadly, he ended up with secondary tumours, and the cause of the back pain was due to secondaries in his spine. And sadly, he died through the course of this investigation. But what we found through that is there was a really mixed model, with some GP practices operating continuity of care and some weren't. We found that with the GP IT systems, there was no requirement for those to consider continuity, and particularly how you can prioritise or bring up a flag to say, actually, this person's been in with back pain, you know, this many times over the last however many months or years. So there wasn't a very easy way of identifying or prioritising that continuity of information with some of the GP IT systems we used. We found the benefits of continuity of care. Actually, we found that GPs who were working in practices with systems of continuity often had more time planning processes and carrying up follow-up actions. And we also found that there was better staff welfare in those practices, with better retention and fewer recruitment issues. So we found lots of benefits of continuity of care. And so we were concerned about the safety impact of lack of continuity of care. And on the back of that evidence that we collected through that report, we wrote to the Department of Health and Social Care, and they're actually looking at how they put continuity of care as a requirement in the practice that the contract that the NHS has with all GP providers. So that was one example of some work we did in primary care. I just wanted to talk next about the work we've done in workforce and patient safety around digital tools. Now, we all know that in order to meet the demands of the future kind of changing demographics and the future requirements of complexity, that actually digital tools are going to be vital in how we can, and innovation is going to be vital. But I think this is an example of actually how we really need to think about really carefully about the implementation of any new technology in it being used. And what we started to look at the triage tools that people were being used. And increasingly in the UK, people are being asked to go through a digital triage tool to actually access primary care. And there's a variety of ways of doing that, usually a form that's linked to our NHS app that people fill in. But I think there was a few things that we heard through the course of that investigation. Firstly, that the consideration of inequalities was not being considered enough. So some people love digital tools, but we know that some people couldn't access them for a whole variety of reasons. They struggled to get on the forms. They weren't necessarily easy for people to access, and so that was a really big factor. And certainly we see lots of examples in our investigations of where inequalities are just amplified in patient safety, and there is that direct link that we need to understand and do more about. We heard very much that incidents are not always reported. And again, I think this is where we need to think in primary care about how do we generate that culture that feels safe and feels able to report when things are not going wrong. And we saw kind of a general culture of unreporting in general practice. Now, that might be very different in other countries, and it would be interesting to hear if there's any areas that have cracked it. But certainly in the UK, we have that culture of underreporting areas. And we know from all of the research into patient safety that unless we get that good reporting culture and that understanding of what's going on in patient safety, it's very difficult then to make the actions that are going to improve things. We talked about the fact that online tools were often just kind of put into a practice without the specific training that was required and the kind of support for practices, and that often it wasn't considered as part of the overall pathway. And this is something we hear recurrently when electronic patient records are being implemented or digital tools. And we are going to be bringing out some further learning that we've produced around digital safety in May. But we think that actually that the tools are only as good as the kind of implementation that goes around them. And people often think that they're going to kind of be the savior of healthcare, but actually what we need to do is focus much more on the implementation and how they work in practice. We find often these tools are only tested in offices. They're not tested in real life. So actually, how do we make sure that some of these IT tools and digital tools are tested in real life? And also we've found that often the tools themselves haven't been tested enough with patients and not with the clinicians that need them. And we heard, some of these tools were not allowing clinicians to get the information they needed to make the diagnosis and importance. So we think that when people are procuring these tools, when people are buying these tools and thinking about them, there needs to be a lot more kind of user testing during that process, clinical testing of patients and families, and really thinking through, are these going to be right? And then we also think that there needs to be much more support in terms of implementation. And there's a lot more detail in that report, and I won't go through it now, but there's I think it is important for us to think about digital tools. And I think the same will apply to AI. Increasingly, we're starting to use kind of AI products more and more. I think how we start to use those and how we really think about the tools as part of a pathway rather than just as an isolated tool, I think is really important. And then finally, I'll mention a report that we published this week, which looks at continuity of care, not continuity of care, coordination of care. And I think this is something that we've specifically focused on because we're aware of the growing number of people with long-term conditions. Certainly, we have a very significant proportion of our adult population with long-term conditions in the UK, and not just one, but often multiple long-term conditions. And we know that for some people, navigating a complex healthcare system can be really difficult, and we are often set up, and I think primary care is leading the way because they've always looked at people from a holistic point of view, but often pathways are set up very much for individual disease pathways or individual clinical areas rather than taking a much more holistic view. And we listened to a lot of people who were feeling quite exhausted and often frustrated with having to navigate this complex healthcare system, trying to work out how they got care from different parts of the system across primary care, secondary care, across different areas of care, and including social care. And often we found that people found this difficult and frustrating, and that led to their health deteriorating. We heard about them missing appointments as a result, and care often being delayed or forgotten as a result. Now, this may be just a phenomenon around the NHS, but I think it is something that, as we get those changing demographics and the changing population needs, again, we need to think about. And we've made national recommendations, particularly about how you define coordination of care and how we make sure that it's considered in our long-term strategic thinking at a national level. So those reports go into a lot more detail and hopefully give a flavour of the type of thing that we look at. And I just wanted to finish, I'm conscious I'm running out of time, and I just wanted to finish with a few things, just to say that we need to change the mindset. We need to move away from saying it's human error is the cause, and really thinking about those systems, those processes, those environments, the systemic impacts that create these problems. Need to really think about interactions and feedback mechanisms. And I think this third point is really important. We need to fix processes and systems and not people. And I don't think we've got that message out there enough yet, but it's often, we know we've got a really dedicated healthcare profession right across the world who are trying their best in very difficult circumstances often. We need to really think about how do we support them. We need to think about controls for common hazards. I've talked about that, and really robust controls. We need to involve users much more in testing. We need to think about variability and adaptability. We need to think about those affected and how we support them, and that's patients and staff. And we need to think about just culture as a mindset and not a process. So that's where I will finish. I will circulate these slides. We've got a mailing list, and there's a QR code for there. And there's lots of information on our website, which everyone can access. All of our investigations are published, and so all of the information is on the website. Thank you. So I'll stop sharing.
Thank you, Dr. Benneyworth. Thank you so much I really appreciated that. And I think we all appreciated that, that just overview, and enjoyed your talk. I did not see any questions in the chat, and so I would like to ask some questions, if that's okay. And if you would like to put additional questions in the chat, please feel free to do so. So there are a lot of challenges facing healthcare services at the moment. So how are we thinking that we make sure that there's a continued focus on patient safety?
Yes, thank you. And I think that's a really good question, especially with the kind of economic climate that everyone's working in, and the focus on things like productivity, the focus on kind of other aspects, and certainly in the UK, I think we're at a really challenging time from that point of view. I think there is a lot of focus on people talk about productivity all the time, but actually when they're talking about productivity, they're not talking about patient outcomes. They're talking about the number of operations or the number of outpatient appointments. And I think we've really got to get back to putting safety and quality at the centre of this. You'll all probably be aware of the kind of various scandals we've had in some of our NHS hospitals, so mid-staffs back several years ago, where hundreds of patients died unnecessarily, and the learning from that has made some changes over the last few years, but we're not sustaining those changes. And I think at a time of such kind of economic uncertainty, I think that's why I put the economic slides, because I think we've got to bring the money argument into this much more, because until we do, I think it won't be prioritised. I think the other thing is the staff well-being argument, because actually we know the direct correlation between the health and well-being of the people that work in health and care and patient outcomes. And we can't just expect people to we know there's high levels of burnout. COVID has changed things significantly, so let's put staff health and well-being at the centre of things as well, and that will improve outcomes and improve retention and recruitment of staff. So I think there are challenges, but I think actually if we work with our governments, work with our organisations we're working with, both at kind of I think we need to be looking at this as a kind of national level, a local level, and an organisational level and an individual level. I think we need to really think about how do we kind of hammer home that safety is going to be the only way we can work through all of those other challenges, and getting it right first time and avoiding all of the demand failure and everything else that comes from poor care.
Great, thank you for that. But if we're looking at people working in the clinics, in their practices, sometimes it's a little difficult to kind of impact that on an organization-wide level. And so how do you have suggestions about how we change our culture of our organization to support safer care?
Yeah, so I think the first thing is thinking about how you generate the safe space for people to talk about things that have gone wrong. And I think that starts with your people's immediate response to when something does go wrong, which is why I raised it. So, if someone comes to you and says, actually this has happened, and the immediate response was, why did you do that? That was a stupid thing to do. Then actually people aren't going to feel safe to actually then come again and talk about it again. And I think the first thing is taking those small steps. The culture won't change overnight, but I think taking those small steps that are going to encourage people to feel safe about raising things. And I think that comes from leadership within the practices and leadership within the organisations, and leaders being kind of putting themselves in that vulnerable position so that they lead by example in talking about things that they might have had happen to them that don't go well. I think it's important to create the space, and I know that everyone's time is very precious and actually demands are huge, but actually creating the space for people to come together to talk about how does the team work together, to talk about the safety concerns that people have. And often I say, give the example that actually if people saw something on the floor that someone was going to trip over, they would say, actually there's a cable there, we better move it because someone's going to trip over it. We're not so good at doing that in healthcare, I don't think. We're not so good at saying, actually there's a risk and I'm worried about this risk, and actually can we discuss it as a team? Some places are good at it, some places I think sometimes we don't raise things until something has actually gone wrong. And so I think it's actually, how do we start that conversation and start to think about where are those risks and how do we surface them? I think that's the first thing, surfacing those concerns, surfacing those risks that people see, and then actually so we can really take practical actions to deal with them in a systematic way.
Great, thank you for that. I don't see any other questions, but I have one or two others. So what should we consider if we have to invest investigate a patient safety incident? Do you have any sort of like guidelines for that?
Yeah, certainly. So we have, like I said, a whole range of kind of resources for people if they want to undertake an investigation or need to take an investigation. I think the thing for me is firstly making sure, as I mentioned before, how do you really involve patients and families well? I've spoken to many families who've said they've been held at arm's length when an investigation has occurred, and they think, well, actually this is about me, so I should be involved. But the natural reaction of some investigations is to say, no, actually we'll hold you at arm's length, probably because people are worried about what the consequences are going to be afterwards, and are worried about that kind of sense of blame. But how we kind of work with families is really important. And often I think we see some of the most difficult cases are where families haven't been involved well in that early stage, and then it leads to complaints, it leads to litigation, it leads to other things happening, which can be very protracted and difficult time for clinicians involved. So that early stage is important. I think the other thing is to really listen to what people are saying, to create the environment so you're able to hear from staff members involved in a very non-judgmental way, in a very much way that actually really listens to their story, really think about. We use something called SEEPs. I don't know if people have come across SEEPs, but it's the Systems Engineering Investigation. No, I won't forget I've forgotten what the P and the S is for patient safety. For patient safety, and Systems Engineering Initiative for Patient Safety. Sorry, I should have got that right. But essentially, it's a mechanism of one of the tools that our investigators use as part of their investigations that really starts to look at the tools, the environment, the systems, and how they interact with the person in that mix. And we've moved away from root cause analysis as a methodology because that feels like it ends up looking at the person, and also most incidents don't have a single root. Most of them, there's a complex reason why they've occurred. So a whole range of resources available. But what I would say is, I think it's really important to recognise the importance of investigation, recognise the importance of doing it well for families, for staff members, and most importantly, recognise the importance so that the learning is shared back into the system, and importantly, that the learning leads to the change, so we prevent these things happening time and time again, which is sadly what we see.
Great, thank you. In listening to you talked a little bit about the electronic medical records, electronic health records, and AI. So AI, of course, is dominating a lot of what people are talking about, what its impact on health, what do you see as a possible role for AI in patient safety, knowing that it probably can help, but it's probably not the answer for everything. I was just curious what your thoughts were on that.
Yeah. So I think there's huge opportunities actually, and I think the states are leading the way in this. I listened to a talk the other day, listening to some amazing stuff around recognising sepsis and deterioration, and the kind of scanning of EPRs on a 20-minute basis to pick up deterioration in patients in inpatient units. And I think there's an awful lot we can do to look at data and use AI to kind of identify trends in data, to identify where there's concerns and emerging risks. So I think there's a huge amount, and I think there's an awful lot around productivity we can do to free up clinicians' time to be having those really good conversations with people, to listen to patients. So things like the ambient AI that's being used to kind of summarize people's notes and to kind of write clinic letters and things like that, and the kind of ability to summarize people's notes. And then I think there's something about actually how do we use AI to empower patients, and there's some lovely stories around that. I don't know some of you may have come across Sue Sheridan from, I think, Patients for Patients in the US again, and she gives this lovely story about how she went and was misdiagnosed around her Bell's palsy and used ChatGPT, which kind of accurately diagnosed it, and then you know, really empowered her to go back and make sure that she got the correct treatment. Now, I think that's something as clinicians we're going to have to go on a learning journey about, because I think it's you know, it's going to be interesting to be challenged, you know, and have that discussion. And I think we need to be very open to thinking about how do we work in partnerships with patients as everyone's learning around AI, and how we all kind of find our feet with it. I think in general practice, there's also some really interesting things going on about diagnostic support and other areas. I think with all of it, though, I think there are risks, and I think the risks, you know, quite well documented in terms of the potential biases in AI that we need to understand more fully. I think there's risks about implementation. I think there's risks about the quality of the AI and the algorithms and things, and actually how does that feed in, and, you know, is it a medical device or isn't it a medical device? And so I think we've got to go into this with our eyes wide open. And what I would say is that actually we need to make sure that patient safety is right at the core of that spread and adoption of AI, so that we fully understand as we take those steps the safety issues and how they're being mitigated as we go forward.
Yeah, and I think there is a lot of you know, move towards, you know, what the EHR can do using AI. You know, maybe, but you know, there's maybe some concern as well about people being still inundated, like physicians being still inundated with alerts and what's, you know, so, and I'm just, you know, curious if there has been any work around that, because AI sounds like it may bring an additional layer of, okay, things that I have to scroll through before I actually get to finish my note, which I need to do. So, you know, how would we sort of temper that? Because that would be also a concern with AI just adding to the administrative burden of that. And I know we have about 6 minutes left, so but just curious about that being an additional barrier for physicians, given time constraints, patients in front of you, that kind of thing.
Yes, and I think I don't know of any particular work in that area, but I'm sure it is a risk, because actually if any of these things, if they're not fully thought through before implementation, they can cause significant issues, can't they, in terms of just adding another thing to do, another layer of bureaucracy. And that's what we need to avoid. We need to kind of streamline and simplify for clinicians so that they actually have the time to care. So I think it's a really important question, and I don't have a good answer for that, but I think it's something that we do need to encourage people to consider.
Yeah, but it goes back to your point about using end users, right? So if we're going to introduce it, then we need to make sure that the physicians have time to track it out, test it out, you know, whatever is implemented. But so I think we're almost at the end. We have about 5 minutes left. I don't know. I think Marta's put her contact information in there, and I don't know if there are any additional questions. I don't see any in the chat, but I want to thank you all and Dr. Benneyworth for her time today and for your interest. And we look forward to, you know, much more work has to be done, obviously, because, you know, things are happening every day. But just thank you for this very informative session about how we can, you know, make sure that we keep patient safety at the top of our list, in front of our organizational leaders, in front of, you know, other physicians. We really appreciate your information today, and we'll definitely take back these points to our practices and our organizations.
Thank you. Thank you for inviting me.
Thank you very much.
Thank you so
Wonderful.
much, Rosie.
Thank
you.
Terrific. Yeah.
Thank you.
Thank you
very much.
Mhm.
Thank you.
Thank